I'll be presenting clinical cases on the use of integrase inhibitors in Africa. There's my disclosures and ethics clearance. To give you all context, I come from South Africa, a country where Nelson Mandela fought for freedom and equality of human rights, but unfortunately this has not yet been achieved successfully. We still have first world cities, such as Johannesburg and Cape Town, with peri-urban townships such as Soweto and Khayelitsha right next door. And we have some very rural areas which lack water, electricity, and sanitation. Our health system is plagued by this inequality, and it is burdened by 7.1 million HIV-positive patients, a national prevalence of 12.5%, and important to note that 90% of our HIV is subtype C. Our health system has two sectors, the private and the public sector. The public sector serves 84% of the population, the majority of our HIV-positive patients, but unfortunately 70% of our doctors are working in the private sector, serving only 16% of our population. The public sector is guided by essential drug lists and national guidelines. We only do genotype testing after second-line failure, except for very specific situations, such as an HIV-positive neonate with a mother on second or third line. And although we've already been talking about how we're going to have INSTIs in our future guidelines, currently they can only be prescribed by our National Third Line Committee. And how that works is that any clinician throughout the country can apply to the Third Line Committee when they find a patient with proven PI resistance on the genotype, and the Third Line Committee then decides which ARVs can be used. In contrast, the private sector has very little regulation, only through funding through medical aid companies. The Third Line Committee developed an algorithm which is it's not fully evidence-based, it's just a tool to aid them with prescribing ARVs in an equitable way that's transparent and can aid in future decentralization. So how they made this algorithm is that if there is greater than or equal to low-level resistance to either lopinavir or atazanavir, then the patient gets darunavir ritonavir plus 3TC or FTC plus either TDF or AZT, depending on which has least resistance. Then they look at intermediate resistance to tenofovir or AZT and low-level resistance to darunavir. If either of these criteria is present, the patient gets raltegravir, or now dolutegravir, since it's been available. And if both of these criteria are present, the patient gets etravirine, unless there's greater than intermediate resistance to etravirine. So again, it's just a tool that they use to aid. So in our public sector, we have over 1,500 patients on third-line ARVs, and out of 1,415 of these recorded regimens, we have all 100% on darunavir, ritonavir, 515 patients on dolutegravir, and 433 patients on raltegravir, and 223 on etravirine. So when this is put into the context of our almost 5 million patients on first line, almost 150,000 patients on second line, the percentage on an INSTI is extremely small, less than 0.05% of our public HIV-positive patients. So we already know, and we've gone through today, our INSTI resistance mutation pathways that commonly go down the 143, 148, or 155 pathway. So I'll be presenting 3 cases, all with INSTI resistance, and two come from South Africa and 1 case comes from Zimbabwe. These cases were collected through the Right to Care clinical helpline. So the first case is an 11-year-old boy from South Africa. He was born in 2006. His mother was not on ARVs during pregnancy or breastfeeding, and he received only statinavirapine after birth. Our PMTCT program has come a long way since then. He was diagnosed with TB and HIV at 6 months old and received 6 months TB treatment, and after 3 months was started on ARVs, stavudine, 3TC, and lopinavir ritonavir as per the guidelines at the time. with ritonavir super boosting because of the rifampicin. His baseline viral load was 300,000, and it came down to 670 after 6 months. But unfortunately then, it did not fully suppress. His CD4 percentage first decreased, then increased nicely to 35%, and at this point he was transferred out to a local clinic, and the records are incomplete. After 6 years of being on ARVs, he returned to the hospital with a viral load of over 3 million. It is assumed he was on the same regimen. He was then changed to the current second line at the time, abacavir, AZT, efavirenz, and lopinavir, ritonavir. And again, his viral load did not suppress. So the first resistance test was performed 8 years after first starting ARVs. In this genotype, we can see 4 major PI mutations, some TAMs, M184V, and K103N, as well as L100I, causing widespread resistance to all 3 classes. And our INSTIs were not tested as they are not routinely tested in genotypes. They have to be requested. He was 9 years old at this time, so he was started on darunavir, ritonavir, abacavir, 3TC, and raltegravir, as per the third-line algorithm. His viral load again did not suppress. He clearly had poor adherence, and it went up to over 1 million. A second resistance test was performed, including INSTI resistance. Here I've made a composite of the genotype results, showing in grey the mutations that are archived, in black the remaining mutations, and in red the new mutations. So we can see here some new accessory PI mutations, and here M184V. I didn't comment that previously oh no, that's fine, sorry. And here we see no INSTI mutations. He was left on the same regimen and counseled on adherence. Again, his viral load did not suppress. So at this point, he was labeled as failing third line, and a third resistance test was done. And this was done recently. Here we see development of further NNRTI accessory mutations, K65R development, increasing the tenofovir resistance, even though the patient has never even been on tenofovir. We see major PI mutation 32I and accessory mutation 33F, increasing our PI resistance as well. And here we see our INSTI mutations. So to look at them closer, this patient went down the 143 pathway with the accessory mutations T97A and G163R. And we can see here that most of the effect is on raltegravir, with some cross-resistance to elvitegravir, but minimal, if any, effect on dolutegravir. So you can see this is according to Stanford's scoring. At this point, a tropism test was performed, and unfortunately was CXCR4 tropic, so maraviroc was not an option. So this case was discussed with Jonathan Shapiro, and the child was at this point 11 years old and 26 kgs. And we decided on the regimen darunavir, ritonavir, BD at high dose. Dolutegravir also we went for high dose BD, actually 50 milligrams BD, so it's the very high dose. And then FTC and tenofovir. This patient has just started the regimen 2 weeks ago, so we're hoping that the viral load will show suppression. The second case is a 21-year-old female from South Africa. She was born in 1997 and diagnosed with HIV at 8 years old. She was initiated on stavudine, 3TC, and efavirenz, and changed to second line after 3 years to AZT, DDI, and lopinavir, ritonavir. The first resistance test was performed 3 years after this, and showed the following mutations. Again, we have multiple major PI mutations, some TAMs, and notably the absence of M184V there because she was on DDI, not 3TC, and K103N. She was 15 years old at this point, so she was given darunavir, ritonavir, tenofovir, FTC, raltegravir, and etravirine, according to the third-line algorithm. Her viral load again remained around 5 log and came down a bit to 3,000. But a second resistance test was performed 9 years after starting ARVs. And here we see additional NNRTI mutations, M184V coming into play, additional accessory mutations to the PIs, and now some INSTI mutations. This patient's INSTI mutations went down the N155H pathway with the accessory mutations T97A, as well as 157Q and 151, which are thought to have little effect. Again, we can see mostly cross-resistance from raltegravir to elvitegravir, and less impact on dolutegravir, but some impact this time, which puts our Stanford scoring into those positions. The Maraviroc tropism test showed CCR5 tropic, so this patient was able to start Maraviroc, and as they were 17 years old, the chosen regimen was Maraviroc, dolutegravir, darunavir, ritonavir, TDF, and FTC. Now, unfortunately, we did not have dolutegravir available at this point. So the teenager was given a holding regimen of tenofovir, FTC, AZT, and abacavir. Her CD4 count unfortunately dropped, and then dolutegravir became available. She was started on that chosen regimen, and her viral load suppressed for the first time. She remains virologically suppressed to date, and she has been counseled on the latest news that Rebecca just presented to ensure that she's on contraception. Now, our third case comes from Zimbabwe, and it's a 17-year-old female who was born in 2001 and did not receive any PMTCT as her mother was not known HIV positive at that time. She was diagnosed with HIV at 9 years old and initiated on stavudine, 3TC, and nevirapine. There was a guideline change after the first year from stavudine to AZT, and then she developed immunological failure as there was no viral load testing at this time in Zimbabwe, and was changed to the second line AZT, 3TC, lopinavir, ritonavir. There was again a guideline change 2 years later where she changed to abacavir, 3TC, atazanavir, ritonavir, and now viral load testing was introduced, and we see very high viral loads, over 4 million. So the first resistance test was performed 6 years after starting ARVs. Here we see again 3 major PI mutations with an accessory, 2 TAMs with M184V, and K103N with some accessory mutations, and INSTIs not tested. She was 14 years old at this time, and the decision made for her at this point in time was to give her darunavir, ritonavir, 3TC, and raltegravir. Her viral load then reached a minimum of 87. However, generally remained around 5 log. She was changed to 3TC, darunavir, ritonavir, dolutegravir when dolutegravir became available, but her viral load remained at 5 log, and a second resistance test was performed. In this resistance test, they only found 1 new PI mutation, which affects darunavir resistance, and so they were worried about future development of PI resistance and put her at this point onto a holding regimen of 3TC monotherapy, because as you would have realized from this case, she had very poor adherence throughout, and despite numerous adherence interventions and counseling, this did not improve. So she was put onto 3TC monotherapy, but unfortunately her CD4 count dropped, and she developed pulmonary TB and had to start 6 months of TB treatment. After these 6 months, she started 3TC, darunavir, ritonavir, and dolutegravir again. As adherence was still a problem, she received 16 weeks of directly observed treatment, and her viral load remained high. So a third resistance test was done, and this was done very recently. This resistance test unfortunately now showed a further major PI mutation affecting darunavir, as well as INSTI mutations. These mutations went down the 148 pathway with accessories 138K and G140A. So unfortunately now we can see this patient has high level resistance to raltegravir with cross resistance to elvitegravir and dolutegravir. And we do not know fully what to do with this patient. So thoughts at this point in time, the Maraviroc tropism test unfortunately was CXCR4 tropic. So that is unlikely to be useful. So at this point of time, she's 17 years old, 41 kgs. We would love some input from the experts. I suppose we are considering etravirine, tenofovir, FTC, darunavir, ritonavir, and high-dose dolutegravir. As you've mentioned previously today, that it can still be useful at that very high dose, and luckily Dr. Natella presented that the safety is quite good. So that's all good news for our patient. So the plan is still in the process. Resources are limited in Zimbabwe, but input will be welcomed. So looking at the three cases, the first case followed the 143 pathway, luckily not giving too much dolutegravir resistance. The second case followed 155 pathway, and the third one unfortunately followed 148 with two mutations, with two accessory mutations. Now I know that 148 pathway is supposed to be more common in subtype B, whereas I'm assuming this patient was subtype C. And I think the reason for it being more common in subtype B is because of the accessory mutation G140S, which only requires one base change to be formed. But in this patient, the accessory is actually G140A. So in conclusion, although we see very few patients on INSTIs in the public sector in South Africa, we are starting to see resistance with raltegravir. The resistance patterns follow the three common pathways, and these resistance mutations can lead to dolutegravir resistance. INSTI resistance is possibly unidentified because our INSTI genotyping is only done when requested, and in the private sector, it's more likely to be common, as INSTIs are more commonly used. So we feel that we should try to avoid using raltegravir in cases where future dolutegravir may be compromised. And this again brings up the dilemma of the WHO guidelines, including raltegravir to an early age, which is on one hand a great movement, but on the other hand, according to resistance, we are a bit worried. So what is the future of integrase inhibitors in South Africa? I think we've already had a lot of discussion on this today. What we were planning was to change all our patients' first line and second line to dolutegravir regimens. And then in the future, the first line would be dolutegravir-based with tenofovir or TAF when that becomes available in South Africa. I think it'll still be about 2 years. And our second line, hopefully we wouldn't have many second line patients then, but would probably be darunavir, ritonavir-based. And now, what do we do with our females at reproductive age? You've spoken very well on that already. So we do have some dilemmas in this picture. Our genotype testing will also need to change. We will have to change from just doing genotype testing after second line failure to also after first line failure, just so that we know what is going on for later use. Other African countries might not be able to afford these genotype tests. I know there are some countries where genotype tests are not available at all. So we will need to keep good records of resistance patterns to inform guidelines. And other important aspects of rollout that have already been mentioned today is the cost of the ARVs, as well as the viral load testing, as well as the genotype testing. The healthcare worker capacitation, that will be very important in terms of viral load monitoring before switching, knowledge of drug interactions, especially rifampicin, genotype testing after dolutegravir failure, and the possible risks in pregnancy. And then INSTI resistance records will be very useful, as well as the records of the clinical outcomes of these patients who have had such strange third-line regimens given. So can integrase inhibitors help us to achieve the last 90? I'm optimistic that they can with the correct guidelines and a well-implemented process. So I'll end with a quote from Nelson Mandela, that it always seems impossible until it's done. Thank you.